Good morning, good afternoon, good evening. I'm going to talk about WHO's perspective on HIV prevention and what are the gaps. Over the past 4 decades, there's been a huge advance in HIV prevention. Starting at the beginning of the epidemic, of course, there were really only condoms. And now here we are 40 years later with a whole range of prevention options. And this has been a huge amount of work with numerous trials. And on this slide, you can see the various pivotal trials and how WHO has responded to produce recommendations to these effective trials. WHO is part of the UN Global Prevention Coalition, and we look at prevention across 5 pillars. This isn't a perfect way of looking at prevention. There's no real perfect way, but it's a pragmatic way, and I'm going to base this presentation on those 5 pillars. So starting with adolescent girls and young women. It's long been recognised that adolescent girls and young women, particularly in Southern and Eastern Africa, have a much greater vulnerability to HIV, a much higher prevalence and much higher incidence than their male counterparts. And that's focused a lot of attention and funding on interventions and programmes for adolescent girls and young women, supported by countries, supported by PEPFAR under DREAMS, and supported by the Global Fund, etc. And this has really provided comprehensive interventions across structural, biomedical, and social arenas. What has been a big gap, really, there's been an awful lot of talking about sexual reproductive health and HIV integration over the past 30 years, but the big gap is actually doing anything. And with the results from the ECHO trial in 2019, trial looking at different long-acting contraception methods, what was really shocking in this trial was the high incidence amongst women attending contraceptive services. So WHO and Global Fund and reproductive health colleagues are really now focusing on trying to join up reproductive health services and HIV services in family planning clinics to offer HIV prevention, STI prevention, etc. in these services. So what are the real gaps for women? I think we all recognise women need choices and they need greater prevention access. We also have to recognise that women are all not the same, and the women's needs in different geographies where there's different epidemiology. There are differences with individual risk and vulnerability, and services and prioritisation need to reflect that. HIV, STI and cervical cancer and contraceptions need to be joined up. Women don't need to go to 4 different settings for these services. Structural issues are important, and always listening to women how they want services delivered. Key populations. If there is one thing that I would like you to take away from this presentation, it's about we need greater focus on key populations. 65% of new HIV infections are in key populations, and outside Africa, this is 93%, and that certainly does not reflect the focus and current spending on HIV prevention. WHO for the past decade has had comprehensive guidance for key populations, focusing on health interventions and structural interventions. We're updating that at the moment. We also are including STIs and viral hepatitis, as again these disease areas are also very prevalent in key populations. So what are the main issues? There are many good examples of good key population, high quality key population services, but they often don't reach the majority of key populations in the country. So we have to find ways of expanding those, supporting what key population services would find most acceptable, key population-led services, thinking about what they need to include beyond HIV, STIs and hepatitis, really looking at what are priorities for key populations, mental health, looking at structural issues, gender-affirming care for transgender populations, and antenatal and contraception services for women, looking at partners of key populations. But really what I want to emphasize is the scale. And I think one of the reasons is we have such low traction in supporting key populations. We don't have that ambition. We often have really low population size estimates, so a small program will seem a great success. So WHO and UNAIDS have really been supporting countries to have more pragmatic approaches to estimating their population size estimates, so that they can have programs that actually reach and cover these populations. Looking at voluntary medical male circumcision and reaching more men. Medical male circumcision is one of the interventions, but we need to reach men more broadly. Men have less access to health, to testing. They have much less access to antiretroviral therapy. They're much less likely to be viral suppressed, which means that they can pass HIV to partners. So we need to reach, test, linked treatment, linked to prevention. That would be huge benefit to men, but also to their partners. Voluntary medical male circumcision has a 60% lifetime reduction for men. It also has benefits for women. We've known this since 2007 when the trial results came in, but the uptake has been relatively slow. However, there's been a great uptake over the past 5 years, and it's now reaping the benefits. VMMC with ART has really started to bring down infection rates in high burden countries. COVID has disrupted this, so we need a bit of a catch-up plan now to make sure that the younger men who are coming into that age group can be offered male circumcision. So what are the main gaps for men? They've often been really left out of the HIV response in high burden areas. They can be reached. They can be reached through health services. We often think men don't go to health services, but they do. And recently, Kate Dovell presented this in a paper from Malawi. They can also be reached through workplaces. ILO has great reach through HIV programs in workplaces. They can be reached through sport. They can be reached through their partners through notification and online. And it's not all about VMMC. We must also think about opportunities to integrate other health services for men. Condoms. Condoms were really the mainstay of HIV prevention for the first decade and into the second decade, and have been responsible for preventing huge numbers of HIV infections. But we've really lost our way on condoms, and we need to reinvigorate and support comprehensive condom programming. I'm going to now focus on PrEP. PrEP has, over the past decade, really reinvigorated thinking about HIV prevention more broadly. From the first trial in 2011, the IPREX trial, which showed the first trial to show the benefits of PrEP. Over this decade, there have been numerous other trials, really reinforcing that PrEP is highly effective across populations. And WHO has responded to this guideline at every juncture when new evidence comes out. Since WHO recommended PrEP for people at substantial risk in 2015, there's been a steady increase in countries adopting PrEP in their country plans on HIV prevention. And there's also been a steady increase in people accessing PrEP. And the green area here is the African region, and you can see that there has been quite an increase in PrEP access. However, it's not enough. It's not enough to have a community-based impact on the epidemic at the moment. That being said, in some high-income countries, particularly where the HIV epidemic is focused on men who have sex with men, it really has been having an impact. Where combined with high access to testing and treatment, adding PrEP to that mix has really started to see incidence amongst MSM really start to fall. And this example on the right here from Australia, from Andrew Goodic's team, is one of many. It's probably the most well known, but this pattern is also being seen in Europe and in the US. Very little data on the community impact of PrEP in low-income countries. On the left here is from Search, which is one of the few examples which again shows that PrEP, when offered to communities, can bring down incidence. WHO is updating its implementation guidance to really support simplifying PrEP so we can decrease costs, increase accessibility, and hopefully make PrEP more available to have a much greater impact. And this guidance, we're working on it on the moment. You can see what we're looking at. We're also doing a survey, so please, if you're a PrEP provider, answer our surveys so that we can learn more about how PrEP is being implemented in communities. The dipivering ring is something else that WHO has recently had a recommendation on. One of the problems with oral daily PrEP is that people find it difficult to take a tablet every day. So there's a great interest in long-acting products. The dipivering ring is the first of these to gain regulatory approval. It has modest efficacy, and so it's an additional prevention choice for people really who feel unable to take a daily tablet, and the ring would be a suitable option for them to help them reduce their HIV risk. There are 2 recent trials on long-acting injectable PrEP. Cabotegravir were highly successful. These were highly efficacious in reducing HIV transmission, and at the moment cabotegravir long-acting is going through FDA approval, and WHO is following this closely and will be convening to consider guidance early next year. It's highly effective. However, implementation is limited in low and middle income countries, so we're really pushing to have more implementation so we can answer some of the questions that will be needed for this to become more widely available, particularly on HIV testing for people on long-acting products. And of course, at the moment, we need to make sure that the price is low enough to make this accessible in low and middle income countries. So what are the real issues for PrEP? We need to, if it's going to have an impact, we have to achieve scale. With the new products, there are many sort of regulatory issues. We have to think about pregnant and breastfeeding women, because in high burden settings, they have high HIV risk and need to be supported to have new products. We need to think about program issues, that balance between making PrEP really simple, but also making sure that it remains safe, and looking at that funding. So new products need to have to come in at a low cost. And then there are many issues on the actual delivery and the monitoring for clients to make sure that that PrEP delivery is safe. So looking at the future. As I said, if one message is think key populations, many people like me who are old started their work on HIV when HIV was a key population epidemic. Right at the beginning, it was really focused amongst key populations, and then of course the burden shifted to more generalized populations, particularly in East and Southern Africa. And there's been great success. Incidence rates are coming down in these populations, but amongst key populations, they're really beginning to rise again, and particularly outside Africa. And we really need to refocus efforts on key populations. We need to think about how HIV fits into universal healthcare and primary healthcare. No reason why it couldn't. It could be really core, but it needs to be really factored into those discussions. We need to push for quick uptake of new products when they're effective and safe, and think about new ways to deliver them that are more convenient for clients, offer more choice, more acceptable, and think about self-care and virtual interventions. There's a big pipeline for new prevention products, really exciting, but there's nothing's going to be magical. we're always going to have to think about choice. Finally, we've all been living COVID for the past couple of years. It's dominated our lives, but we have a lot to learn from COVID. Prevention services have continued through COVID, and we need to learn from these and take these forward. Self-testing and self-collection have really come into their own, thinking about community distribution of prevention commodities through pharmacies, through mobile, etc. Differentiated and simplified service delivery, and the virtual space. I think it's not going to replace face-to-face, but hugely important in getting messages out there, supporting hybrid models of HIV prevention service delivery. So we need to take these to the future, and together with simplification and self-care, I think this is the future for prevention: choice, looking at virtual, simplification, and community delivery. Thank you.